On the Healthy Human Revolution podcast, Dr. Lori Marbas interviews nutrition and lifestyle medicine experts and extraordinary guests whose informative and inspiring stories will empower you with the knowledge to transform your life and health.
Welcome to the podcast. I'm Dr. Lori Marbas, and I'm so excited. One of my favorite people, Dr. Kim Williams, is joining us today. How are you, sir?
Great. How are you?
Good. It's just so fun always to talk to you. Oh my goodness. So thank you so much for taking time out of your busy day.
Well, fantastic. Great to be here.
Oh, wonderful. Well, I've been looking forward to this for some time, and I am going to just dive right in and begin asking some questions about, we really want to focus in on the cholesterol, because as a primary care physician doing telemedicine and lifestyle medicine in general, that is one of the biggest concerns of patients, which I'm sure you're very well aware of. How do we even begin a cholesterol evaluation? So if we have, if the patient's going in, what questions should they be expecting for someone who's trying to look at a preventive holistic approach through medicine and lifestyle medicine? Where should we be looking? Like, what are those really important factors that we should be focused on?
So in terms of cholesterol management specifically, first of all, we have learned over the years to take it in the context of overall risk. When we first it's really been about almost 7 years since our guidelines came out and said that we should be using, cholesterol medicines after lifestyle, and that we should be, focused on that lifestyle, particularly when people are at sort of a lower risk. And when they're at high risk, they still get lifestyle. It's just that you may need to add some medications on. We set up a website that anybody can look up, okay? That's the 2013 guidelines, which is actually where this first started, believe it or not.
Oh, awesome.
We've had several versions, but the very first one that said, that stuff about an LDL level of 70, we're throwing that out. We are now starting to just use high-dose statins for people whose cholesterol doesn't come down, but anyone who has disease is going to need that management. So it was groundbreaking in several fashions, but one of them was the use of a risk calculator. Mm-hmm. And people said, that risk calculator is just going to make us use more drugs. No, I actually was taking some people off of drugs. They had an LDL of 165, which we used to say anything above 160, you have to treat. Then the newest guideline said, no, really 190, because at 190, the odds of you having a bad gene, and it might be in a real so-called heterozygous familial hyperlipidemia, or just a bad gene for high cholesterol, that was actually starting to get pretty high. So instead of 1 in 500, it would be 3% of these people. So 190 is a reasonable cutoff to just start therapy, because we know that the outcome really is going to depend on drugs plus lifestyle to get the LDL cholesterol as low as possible, without which the person's going to have an earlier demise than they otherwise would. Their survival, avoidance of cardiac events is related to the area under the lifetime cholesterol curve, LDL. So that's really where we started. And I would say that we try to do a full assessment. Is the person diabetic? Is the person hypertensive? Age, gender, and ethnicity, with African Americans having, in some cases, almost twice the risk of a non-African American. And so once we have a risk-based analysis, it tells you, this person really needs therapy, but none of those risk calculators or medications absolves the patient from doing everything they can to improve their outcome with lifestyle. It's something that has to go first. And we should be doing it all the time, but sometimes measuring the cholesterol will actually give the person the energy and the interest to actually learn what it is that they're supposed to do to get their cholesterol down and therefore lower their risk. Okay,
that makes a lot of sense for sure. And so when you're looking at labs, so you mentioned total cholesterol and LDL, should both those be taken into account, or should one take some type of precedence over the other?
So I hope your broadcast goes out to millions.
Yes. Yes.
Every once in a while, there's a thing where that happens that kind of like stops you in your tracks and say, my goodness, how do we have this wrong for 60 years? So one of those happened in the last couple of years, and most people have not heard about it, and they need to. And that is the so-called happy cholesterol, HDL, high density lipoprotein, which is supposed to be reverse cholesterol transport. You know, something was funny in that all of the big manufacturers of drugs were working on raising HDL cholesterol. And for the most part, every time they did that, it didn't show any benefit, and frequently it would actually show harm. Well, it turns out the Can Heart publication from really just a couple of years ago and Copenhagen trials both showed what really our jaws just dropped, that the higher HDL you have, the more heart attacks you have.
Really?
And people just don't know this. They're still saying, well, your total cholesterol is high, but your HDL is high, therefore you're okay. Not true.
Oh, wow.
And so anything above about 80 in men and above 100 in women actually increases. So that U-shaped, I mean, the lower part was true. That is, the lower your HDL, the more heart attacks you have. But we didn't understand that it was a U-shaped curve. And so I'm hoping that everyone hears that and they stop telling people that you're safe because your HDL was, XYZ, it's above normal.
Oh, wow.
Now, what that means is that you basically throw out everything.
Okay.
Non-HDL cholesterol is worthless, particularly if the HDL is high, okay? Which means the total cholesterol is worthless, and you really ought to focus on the LDL. And we were fine with that until last month.
Until last month. Oh, great.
Yeah,
Okay.
there's a huge publication, reanalysis of a lot of data that said that it actually is the stuff that we've been ignoring. The IDL and VLDL, the intermittent density lipoprotein and the very low density lipoprotein that correlate best in their data set with cardiac events. Oh my goodness. Now, to be honest, this may be why the vegan doctors were doing so well. Because the vegan doctors would always get the LDL down, and very frequently, if the patient switched over from eating animals to eating a lot of carbohydrates, particularly refined carbohydrates, the triglycerides would go up. And then we would just battle, clean up the diet, do the exercise, get the triglycerides down. So 1/5 of the triglycerides is roughly what your VLDL is. And so we're actually able, with lifestyle, to control triglycerides. Every time somebody comes in with even an upper normal one, it's supposed to be 100 up to 150. I like them in double digits. If you got 3 digits, we're going to have a conversation. Okay, is that alcohol? Was it fried food? Was it an animal? Is it refined carbohydrates? And people don't recognize that refined carbohydrates are everywhere. They think that that bagel is healthy, and they think that a pretzel is okay. Just wipe the salt off the cover. But no, it turns out that these refined grains will generate such a high glucose response, insulin response, raise the triglycerides, and now we find out that they are very important. I mean, we had little hints, and particularly in bypass surgery patients, high triglycerides, more graft occlusion. So, we probably should have been a little bit more suspicious, but for the most part, we've got this really intense relationship. I mean, draw a linear relationship between LDL cholesterol and cardiac events that we didn't really need much else. I mean, we know that lowering it didn't get rid of all the problems, and therefore there was Dr. Ridker and inflammation, and then that's at Harvard, and then at Cleveland Clinic you had TMAO from Stan Hazen's group, all of which the inflammation and the trimethylamine N oxide TMAO occur when you eat animals. So another reason that the people who were doing plant-based medicine were helping the patients. So it's not just LDL, it's inflammation, TMAO, and triglycerides and VLDL.
Wow. Oh my goodness. So when a doctor like myself gets a patient and they're like, I've been on a whole food plant-based diet 5 years, 10 years, whatever, but they have persistent elevated total cholesterol, persistent elevated LDL, let's say like low 100s, and triglycerides most of the time are actually under 100 or up maybe a low 100s. What do you do with someone like that? Maybe they're not diabetic, but they're eating this healthy way pretty well. Where would you begin that conversation with them, or would you even, what would you do?
Absolutely. So you're always annoyed by those people who go look at their phone. No, I'm actually doing this for you.
Yeah, I appreciate you.
Okay,
one
that
second.
was my granddaughter and I playing chess. Are you able to see it? Okay.
Yes.
This is the ACC AHA risk calculator. Anyone can pull it out and download it. And it's a wonderful party tool if we ever have parties again, but we're doing them by Zoom. Uncle Joe, tell me your last cholesterol. What was your blood pressure? Are you diabetic? And you collect all that information, plug it into the computer, and you tell them, oh my gosh, Uncle Joe, your cardiovascular risk, 17.8% risk of having a heart attack, stroke, and death in the next 10 years, you better go see your doctor. And so really that is the best answer to your questions. It's actually embedded in most people who have Epic, and other vendors, I imagine, have programmed it in by now. And so all of the data that you're putting in there, the blood pressure, the cholesterol, everything, and whether in diabetes in their problem list, for example, will populate the risk calculator for you, and you can just hit a command and pop it out. And so then what do we do with that risk, that 10-year risk? We have generally drawn a line in the sand that if someone, like you said, they've been doing the diet, they've been doing their exercise, and they still have these elevations in cholesterol. If you, based on their ethnicity and gender and age and other diseases, if their risk with a high cholesterol is less than 5%, you just keep telling them to keep doing the lifestyle stuff. If it's between 5 and 7.5%, we need to have a conversation, which I'll return to. If it's above 7.5%, we generally say, if you've been doing everything you can, it's time to start using medications, okay? And if you really don't want the medications, which so many of our patients don't want, it's kind of bizarre, by the way, I'm going to interrupt myself. There's so many anti-statin vegan doctors and anti-statin vegan patients.
Right.
And I just have a few things to say. Number one,
please.
I worked for Medicare for 4 years. You get to see the budgetary constraint there. Do you know why they're dying on the vine financially? Because of statins. People are not well and people are not dead. And so you're just killing the payer. You're just killing them, okay?
They're not dead and they're not well.
Number two, if you take the big manufacturer of the original atorvastatin, I don't say brand names on the air if I can avoid it.
Gotcha.
Everybody knows who they are. They made $2 billion off that drug in 2019. So tell me how you make $2 billion off of a toxic drug. You can't. It's just not going to happen. So people who say that statins are bad for you just aren't looking at the data. Now, are there side effects? Absolutely. It's usually muscle symptoms and those myalgias. We have great algorithms. There's actually an app for your phone for statin intolerance, okay? But needless to say, we don't use them unless we need to. And so we do have a lot of people who would prefer not to do it. And that's when we're doing lifestyle. If they're doing all the lifestyle, then we really should have this conversation. Okay, so if they're above 20%, 10-year risk, they just need to go on the drug. And if they can't do that, then do some other drug, but you have to get the LDL cholesterol down. Okay, now between 5 and 20%, the people who you want to put them on, but they don't want it for some reason, or they're asking you for it and you don't want to put them on it because they're 5.6 or so they're a little below 7.5. That's where we use the additional information. And I can tell you there's different varieties that people will do. One is advanced lipid testing. Tell me what your small dense LDL particles are like. Tell me what your LP little a, which is usually genetic. It's a genetic issue. Do you have other kind of cholesterol risk that's going to benefit from this therapy? Now, turns out that statins don't lower LP little a, and they say diet doesn't, but we've done a couple of trials, both myself and Baxter Montgomery, who both have had vegan interventions in our African-American patients that reduce the LP little a by 10%. That may not be a lot if it's really elevated, but at least it's some. So it's not exactly diet unresponsive. But if you have those extra risk factors, even if the LP little a doesn't go down, you want to lower the LDL, and that's why you start the statin. Okay, so that's one set. The next set I actually mentioned, and that would be inflammation. Check your high sensitivity C-reactive protein. And if that's elevated, the risk is almost double of what it would be given the LDL elevation. Therefore, that person probably needs additional therapy. You don't get a lot of CRP elevations in people who are plant-based and exercising because that's one of the first things that's been shown. it's an anti-inflammatory diet and you're protecting yourself. Even when your LDL looks like it's not so good, your C-reactive protein is really good. And then you could say, well, your extra tests are not so bad.
Mm.
There are a couple other, one of them got dinged yesterday in the news, and that is carotid intimal thickness. It's one that we had been kind of relying on. It wasn't our favorite test because of the reported high variability of it, and really depends on who's doing it and who's reading it and what angles do they get. So carotid thickness as a measure of plaque may not be the best. And what happened yesterday is the publication of an opinion by the United States Preventive Task Force, USPTF, saying that carotid ultrasound is worthless, quit doing it.
Oh, wow.
We still have trucks going around to places and doing carotid ultrasound. And they also do, your abdominal, looking for aortic aneurysm. And yeah, it's pretty much worthless unless you're that one person that they find that 6 centimeter abdominal aneurysm.
Right.
And that until they did their little Cochrane analysis, we thought that finding a high-grade stenosis, whether you can hear something there, asymptomatic carotid bruit, we were always worried about those. It turns out that if you look carefully at the literature, and obviously I think the Society of Vascular Surgery and Vascular Medicine actually are kind of trying to rebut it, and I'd love to see how that plays out. But right now they're saying that they do more harm than good because people end up getting tests and therapies for their carotid for things that were never going to go bad, and all they needed to do was to do medical therapy like you would anywhere. If you had peripheral artery disease or cerebrovascular atherosclerosis, coronary, any of them, you would be doing, what I call SAVE. That 4 letters stands for statin, aspirin, vegan diet, and an exercise program. And so,
excellent.
Okay, and so why would you go doing carotid interventions and taking that little risk that you're going to break something off and have a stroke? So it might be a little harsh to say nobody ever should get this test,
Right.
but it's something people should be looking out for. And it's probably not going to be the next machine that I buy, that's for sure. Okay, so I've saved the best for last, and that is coronary calcium scoring. This is something that everybody should know about it. If you've never heard of it, there is a great way of sort of inundating yourself, even though it's 6 years old now. It's on Netflix. It's called Widowmaker.
Yes, it's a good one.
It's a good movie. And so it talks about all of the politics surrounding why it took so long to get it to where it is now. It is now, and maybe because of that movie, it actually is now in our ACC and AHA guidelines to do coronary calcium scoring when you're in that reluctant zone. That is the person who I think that I don't think they really need it. They're below 7.5%, but they're above 5%. So I'm a little worried. I can get the coronary calcium score. If the coronary calcium score is 0, the power of 0 in the MESA trial was so good. We're talking about 10-year risk of about 6 out of 1,000 or 0.6%. That is really hard to reproduce with any other cardiology test. I'm sorry. Okay. And so we really should be doing much more in the coronary calcium scoring. Wow. And so on the other side of it, if a person has extremely high risk, above 20%, we kind of say a negative coronary calcium score doesn't absolve you because, bad things are going to happen. The coronary calcium score does miss soft plaque. It's relying on calcified plaque. But below 20, if someone's, 19%, that's extremely high, but they don't want their statin and they get a negative coronary calcium score, we at least have some basis for saying, yeah, you don't need a statin, keep doing the lifestyle. So, it's a powerful test, and I hope that when people are thinking prevention and lipidology, they'll use a lot more of the coronary calcium score.
What if they have a CAC score of like between less than 100? Is that mean anything, or is it like 0 or all or nothing type thing?
So it's interesting that is the area where you won't get a lot of agreement. So where do you get agreement at 0? You get agreement at about 300. Right. All the hands in the room would say, would you treat this patient? They all go up if you're 300. Most, based on small amounts of data, most people would say that the risk between 1 to 10 is so low that you could have a good conversation about it. Above 10 to 100, that conversation gets a little more intense. And above 100, most people would go ahead and treat.
Gotcha.
I obviously, when I see that calcium score that's not 0, I always look at it myself. And one of the reasons that I do that is that the coronary calcium score is based on a technology of dense plaque that's calcified, and that dense plaque has a score. And that's and we sort of set the cutoff, and this is a standard that goes back, 1984 or 83. So, I mean, almost 30 years. And Arthur Agassiz was the leader in that area. And for reproducibility, they set the cutoff at 130 Hounsfield units. That's how dense the calcium has to be before it actually shows up on the score. Well, suppose it's 129. Well, we know that lipid-laden plaque can be like up to 50, okay? And then when it starts to fibrose, it might go to 75. And then when it starts laying down some calcium, it might go to 100. So I actually do look at all of the scans and look for the non-calcified plaque if there's any you can't necessarily see the low density plaque on that test, but you certainly can see the ones that are approaching 130. And so I use that as a accessory information. The other thing about it, since I'm on a rant talking about coronary calcium scoring, is that everybody should know about it and should look at it. And if I could change the guidelines, it would be to actually have everyone look at it for where it is. Because coronary disease, like pitching and baseball and real estate, is location, 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 right? That is, if you've got a few ditzels and it's down at the tip of the heart, near the apex, if something happens down there, you'll probably never know it. It won't be a big deal. But if it's up there at the top in the left main, or in what we call the proximal LAD, left anterior descending, the one artery with a nickname that we mentioned already, Widowmaker. Well, it turns out that when you get your calcium score, it just gives you left main, left anterior descending, right coronary artery, and circumflex. Well, I want to know, is it in not just don't tell me if it's in the branches, but how high up is it? And so I think we could do more in that area by guiding people if we could tell them where it is, not just how much it is.
Oh my goodness, there's so much there. So I've got another, that was fantastic. Thank you. And so I do have a question for a patient that I saw very recently, and he knew I was going to interview you. And I think it would be a warning. He told me I could talk about his specific case. And it's a young gentleman, 40, African-American, and they couldn't do any interventions with stents or anything, and he had a heart attack last year. Very quickly transitioned over to a whole food plant-based diet, salt-free, oil-free, doing everything right. His cardiologist had him on a very high dose statin. Well, his liver became very inflamed. 3-4 times high normal, and they would lower the dose, the liver calmed down, and then within a few weeks it went back up, and he's having this bounce down. And so his cardiologist stopped the statin. And so here's a gentleman who's done very well. He's lost 50 pounds. He's no longer hypertensive. His cholesterol it's been on the statin less than 100, the total cholesterol. The LDL was like 20 something. It was very, very low. But they just recently stopped the statin. We don't know what that'll bounce back up to. He's not having any angina. He's moving forward. What would you do with someone like that? Would you just monitor the liver enzymes? What would in that scenario, you have someone who had it, can't tolerate a statin, has the lower cholesterol, what would you be thinking?
So many things to unpack there, but let's start at the beginning.
Yes.
Why couldn't they do the standard therapy during a heart attack? And when they say they couldn't be stented, that could be two completely different things. One is it was so-called hit and run, which is more common in women than men, where you have a plaque, it ruptures, you clot on top of it, and then by the time you've gotten your aspirin and you get to the cath lab and that first dose of dye goes in, and boom, it's gone, and you see nothing. And then they say, oh, you had a heart attack, but we can't do anything because there's nothing to do.
He said it was two tortuous vessels, or where it was happening.
That's a tough one. But the other side of it is you've got so much plaque that you're beyond bypass surgery, you're beyond stenting, and you've got so much plaque that nothing can be done. So you're thinking it's more in the milder case or more?
I don't know. That's a good question. He didn't necessarily give me that information. I don't have any reports, but I'm assuming that's the more milder case. Let's go with that direction.
Okay, so yes, you want to stabilize that plaque that ruptured. Okay, best way to do that is to get the LDL down below 55. That's the new ESC guideline, and this actually, if they have an LDL of 25, you should be able to find a dose that doesn't have the hepatotoxicity.
He got down to 10 and still had an issue.
Okay, but 10 of which?
He had the atorvastatin.
Atorvastatin. Okay, so rosuvastatin 5 milligrams Monday, Wednesday, Friday. I would do that, and that's my last ditch. Okay.
Okay.
If it increases the liver enzymes, then I think we're pretty much done with statins. Now, one of the things that we have to recognize that so much of what we thought was liver until about 2012, when the FDA of all people said, "Can you guys please stop checking liver enzymes and muscle enzymes? It's not worth the money. It just doesn't happen very much." And I had been doing every patient, every visit. And, and then I looked back and said, "Oh, they can't be right." And oh my gosh, they're right. These are completely worthless. When's the last time I stopped somebody because of an elevated CK or liver enzymes? So that would be one. Is the experience agreed with the FDA. Number two is that I think that time period where we were doing them, we were missing a lot of hepatitis C.
They did measure, I believe, his hepatitis panel, and that was negative. So
good. Okay. So and the modern times we don't miss it as much, and we've seen the incidence of liver enzyme elevation with statins go down because because it never was the statin. It wasn't okay. But if it goes up and down with the statin, you can feel pretty good saying that it's the statin. So then you start thinking about non-statin therapies. Okay, so the ones that I'll mention them first because they're out there, they're in the literature, they have randomized trials showing that they reduce cholesterol, but they don't have as outcome studies. You're sort of assuming that if the LDL goes down, things are going to go well. But that would be berberine, okay, and tablets, right? Bergamot. My favorite tea is made out of
Earl Grey. Yes.
Absolutely. Brazil nuts. Okay, has a randomized trial. Indian gooseberry.
Yamla.
Psyllium. That is like I'm starting to say a brand name.
Psyllium.
Psyllium.
Okay.
Yeah.
Okay.
It's a husk. Psyllium husk.
Oh, psyllium husk. Got it.
Okay. And so I don't want to say a brand name. But
no, that's fine. That's fine.
They usually use it for constipation.
Yeah.
But it grabs. It's basically soluble fiber.
Yeah.
So it grabs onto the cholesterol and it goes in the stool. And so the issue is you just don't see a lot of outcome trials. You see LDL lowering, but not outcome trials. Then you have ezetimibe, which is the Niemann-Pick-like enzyme 1 in the small bowel. And that does have some positive trials, particularly in combination with a low-dose statin. And that combination, so-called instead of brand name. Okay. So the ezetimibe statin combination does have some in select populations. It's also failed in other populations. Then you've got a new one called bempedoic acid, which lowers cholesterol. It's been out about 18 months, maybe. Okay. And so it's relatively new on the market. I don't see a lot of market share, and that's mostly because people are pretty darn doing well with the statin. And it's coming into the market at a time when people sort of have it in their mind that if a person is statin intolerant and they flunk 2 statins, their drug or their insurance company will cover a PCSK9 inhibitor. So that's an area that's moving on pretty quickly. It started off with antibodies, fully humanized mouse antibodies against the PCSK9 molecule. Why would you ever do that? It actually started with the Dallas Heart finding that there were people who had a genetic abnormality that gave them an LDL of 10 or 7. And that was the first time we knew that humans actually could have that, and your nerves don't fall apart and your brain doesn't go to mush. These are normal people living normal lives, athletic, intelligent people. And so when they saw that this genetic deficiency in the PCSK9 molecule, people started to try to reproduce it. And so one of the best ways to do it was to create an antibody to it, which captures it, disables it. And so your PCSK9 level goes way down. And PCSK9 is supposed to take your liver LDL receptors and tell them, okay, you're done. And you're going to be taken in by the liver and destroyed. If that molecule isn't around, the LDL receptors just keep doing what they're doing, and the LDL falls dramatically. Wow. So with an injection once every 2 weeks, you get about a 60% reduction that stays down every time. If you just keep doing it every 2 weeks, that low level of LDL cholesterol stays way low. So sometimes we use it with statins, not just for statin intolerance, but for people who can't get their LDL down far enough with a statin. And the next thing that's going to happen in this area, people are still working on PCSK9. Maybe it'd be nice to have something other than antibodies. And so our dear friend, like we've been using for coronavirus, messenger RNA.
Oh, really? So
there are a couple products. One of them should be approved relatively soon. It's called inclisiran. And that PCSK9 inhibitor actually is only twice a year.
It's like a vaccine with a booster.
Yeah, kind of like that. And it works really well. So we're anticipating that, the statin therapy will change a lot relatively soon, but,
wow.
We'll see.
Wow. So let's say this gentleman that I was referring to earlier, his cholesterol continues to harbor low. Would you, because he has a burden of disease and this past cardiac events, so of course he's at high risk, where would you move him in his therapy? Would you, of course, we're optimizing nutrition and adding things like the Brazil nuts and the amlo. It's certainly things I do. Where else would you say, let's try some other medications if his cholesterol remained low?
No, not if it's low. If it's below the target of 55, we don't have a lot of data on whether or not you'd even continue to use a statin. That is, all our guidelines saying you had an acute coronary syndrome, or you had a stroke, or you have peripheral artery disease, or whatever, you're going to get high dose, maximum tolerated dose of statin, and getting an LDL less than 55. If you're able to get it down with lifestyle, we know that statins do other things. And so you may feel like you're missing something, but in the plant-based population, I think it'd be unusual to have a high C-reactive protein.
Right. It's very LDL, rare. I measure them all the time.
Exactly. And if those are low, then maybe the person gets a pass, but it is a data-free zone. It's a bit of conjecture on our part, extrapolating from the literature saying that for every 39 decrease in your LDL, you get a 22% decrease in future cardiac events.
Wow.
That's pretty powerful. And so if your LDL is really low, maybe you don't need anything else, but that's kind of one of those things we'd love to see.
Okay. And then, so that brings me to a question referring to someone who has disease. What about someone who was a horrible diabetic, had high cholesterol and had hypertension, but then they go on and switch their diet, they reverse everything, but they've been on a statin because of those risk factors in the past. They reverse everything. I mean, everything looks great. Would you pull someone off that with the cholesterol? Is that number that previous risk factors were there, but they haven't had a cardiac event or known cardiac disease, but now those risk factors are gone? Where would we start that conversation about stopping the statin that was maybe already started?
So I got two thoughts.
Okay.
One
the risk factors, yes, calculator.
My granddaughter and I playing chess. No, I would pull out the risk calculator.
Okay.
And if the risk is below the 7.5, then they really don't need the statin anymore.
Okay.
Now, the problem with that is that we do have a sort of a follow-up calculator. It will now tell you, is this a repeat of, and it's a slightly different algorithm, because remember, those LDL cholesterols are going to be really low because they're on the statin. So you kind of have to, if you are inclined to take them off, then you take them off and follow them very carefully.
Gotcha.
The other one that, of course, I want to say, which I talked about a few minutes ago, is coronary calcium. That if the person has a coronary calcium score that's elevated after all of those risk factors for years, then they probably should be on both aspirin and a statin if it's high enough.
Okay. And so I did have a question. So I had someone who has in that gray zone. So maybe their total cholesterol is like in the 170s, but their LDL is maybe either like 104, 110, something like that. They have no cardiac events, minimal risk factors other than age and gender being male. And we go and I do the calculator with the patient because I can share my screen and do it, telehealth. It's really awesome. I put in their total cholesterol, not on meds, is less than 130. The calculator tells me error. So what do I do with that?
So
but their LDL is a little bit higher though. It is above 100.
So it really is hard. It's hard. That means your HDL is almost absent. They have less than 130 and an LDL still of 100. That means your non-HDL cholesterol is less than 1. So you'd have to have, triglyceride of your Sioux size and almost no HDL to happen. So if that happens, patient is at a little bit of risk, and I really would go heavy with the lifestyle manifestations to lower LDL.
I mean, these people are perfect. Like if you look at a perfect plan eater, like we're limiting, I mean, he's amazing. Like he's doing really well. No oils and all, I mean, just no salt. It's very, very good. So we made the decision that he just watch it. And I mentioned the CAC score and that they're considering it. So
it's $50 at most places. It's well worth it.
Yeah, and it's easy to order. Okay. Awesome. Well, I know you have another meeting, but thank you so much for your time, Dr. Williams. We could talk for hours.
We could. I really appreciate it.
Thanks for watching, and I hope you enjoyed that video. Before you go, though, please hit the subscribe button and the alert button so you will be notified whenever we upload any new videos. On Monday, we upload the Healthy Human Revolution podcast. Now, if you'd rather listen to the podcast, you can find it on all the major platforms, such as iTunes, Google Play, SoundCloud, and even Spotify. On Tuesdays, we upload the Doctors In. This is where I answer your questions. Thinking of that, could you please comment below any questions you might have about health or wellness or any topics that you would like me to cover? Now, if you're looking for more resources on how to start a plant-based diet, sustain a plant-based diet, exercise, recipes, anything regarding wellness, we've got you covered. Check out healthyhumanrevolution.com. And again, thanks for watching.